Chapter 3, Pharmacodynamics. We'll skip over the key terms. We'll go over them in the chapter. The previous chapter looked at how a drug is altered as it travels throughout the compartments of the body. Pharmacodynamics is the study of drugs and their action on a living organism. Pharmacodynamics looks at how the body responds to drugs that are administered. The mechanism of action describes how the drug produces its effect. An understanding of pathophysiology and a drug's MOA can aid decision making about the best drug to treat a patient's medical condition. Pathophysiology is the study of disease in the body. According to drug receptor theory, drugs interact or bind with targeted cells in the body to produce pharmacological action. Most drugs bind with specific proteins in the body. However, they may also bind to carbohydrates, lipids, or enzymes. The location of drug cell binding is called the receptor site. Drug receptor binding is similar to the action of a locking key. The more similar the drug is to the shape of the receptor site, the greater the affinity or attraction that the receptor site has for the drug. When two or more drugs are administered, the receptor site will bind with the drug for which it has the greatest affinity, the drug that best fits the lock. Drug binding to the receptor is usually reversible. Most drugs spontaneously bind and dissociate with the receptor site. Some drugs do not produce their actions by directly binding to a receptor site on the cell. They are able to produce a change in cell membrane stability or excitability through 9 specific mechanisms. Some general anesthetic gases produce their effects via non-specific interactions. Table 3.1 shows the summary of effects of drug receptor binding. An agonist is a drug that binds to and activates the receptor site, eliciting a cellular response. Agonist binding may activate a receptor that was resting or turn off a receptor that was activated. Inverse agonists are drugs that have affinity at the receptor site but produce opposite actions, turn off a receptor that is activated or turn on a receptor that is not currently activated. Figure 3.2 shows the effect of agonist and antagonist binding. Antagonists bind to the receptor site and do not activate the receptor. They prevent another drug or natural body chemical from binding by occupying or inactivating the receptor site. Antagonists block the actions of agonists, inverse agonists, and partial agonists. Naloxone is an example of a pure antagonist. Administration reverses the effects of opioids like fentanyl by occupying the receptor site and preventing the fentanyl from binding. Non-competitive antagonists bind to an alternative site than the agonist to prevent the agonist from binding the receptor. Non-competitive antagonist binding results in activation of the receptor site. A partial agonist behaves like an agonist under some conditions and acts like an antagonist under different conditions. Buprenorphine is an example of a partial agonist. Typically, increasing the drug dose will increase the cellular response in a drug's effect. Many other factors may also influence the strength of the response to a dose of administered drug, such as pharmacokinetic factors like ADME, absorption, distribution, metabolism, and elimination, and individual properties of a drug also influence drug response. A dose response curve shows the relationship between the effect of a drug and the administered dose. The dose response curve shows the drug's relative efficacy and potency. A steep dose response curve indicates that a small change in drug dose will produce a large change in the drug's response. A flatter dose response curve shows that a large increase in the dose of the drug administered is needed to produce a greater drug response. So that shows the dose response curve. Efficacy is a measure of the drug's effectiveness under controlled conditions as opposed to real-world conditions. The efficacy of an antagonist is measured by the extent to which it interferes with the effect of an agonist. Efficiency can be measured for each effect produced by a drug. Efficiency and potency are related. Drugs that have a high efficiency at a low dose are very potent. In other words, only a small dose is required to produce the maximum drug effect. Drugs that must be administered in very high doses to produce a minimal effect have low potency. Drug effects increase up to a ceiling. This ceiling effect may be reached when all drug receptors are saturated or when the maximum possible effect that could be produced is reached. All drugs produce toxic effects that can lead to death. When the lethal dose of a drug is close to the effective dose, the drug is not very safe. The safest drugs have a wide margin between the lethal dose and the effective dose. The therapeutic index is the ratio of the effective dose to the lethal dose. The formula is shown as follows. Digoxin, a drug used to treat heart disease, has a narrow therapeutic index. The drug dose needed to increase the force of heart contractions is similar to the drug dose that can cause the heart to stop beating. Another drug with a small therapeutic index is warfarin. Pharmacotherapeutics is the process of using drugs for the treatment of disease. Drug response is heightened if the patient has had a prior exposure to the drug that produced an allergic reaction and decreased if the patient has developed tolerance to the effects of the drug. Humans are unique and individual variability influences the outcome of drug therapy. The human body undergoes physiological and hormonal changes between birth and death. Age-related changes influence how effectively the body is able to handle drugs. Neonates and infants have an underdeveloped capacity to absorb, distribute, metabolize, and eliminate drugs. The ability of the lungs, liver, and kidneys to process and eliminate drugs declines as human ages. Elderly adults and infants require lower dose drugs. Drug doses for children are often calculated according to the child's weight. However, dose calculations based on body surface area are more accurate than those based on weight. Gender may influence drug distribution and metabolism. The fat to muscle ratio varies between men and women and may influence the volume of drug distribution. Genetics also influences enzyme and protein production in the body. Absence of certain enzymes can produce deadly effects in people who take drugs that require the enzyme for metabolism and elimination. The presence of disease can significantly influence pharmacotherapeutics. More severe drug reactions can occur in patients with kidney disease, liver disease, or lung disease because their ability to distribute, metabolize, and eliminate drugs can be compromised. Drug response may be altered during pregnancy because of pregnancy-related physiological changes. GI motility slows, which can increase drug absorption and drug effects. Pregnancy-related increases in blood volume, urination, and vomiting may alter drug absorption, distribution, and elimination that result in decreased drug response. Repeated exposures to a drug may result in decreased drug response. Desensitization is caused by changes to drug receptors, especially proteins that decrease drug receptor binding or reduce receptor site activation when binding occurs. Sometimes the response to a drug cannot be predicted. Unexpected drug reactions are known as idiosyncratic reactions. Drug therapy is influenced by the patient's belief that the therapy is beneficial. Studies have shown that sugar pills can produce the desired effect if the patient believes they will be effective. This is known as the placebo effect. Few drugs are so specific that they produce only their desired therapeutic effect. Drugs may additionally produce undesired effects. Undesired effects are called adverse reactions. ADRs that produce harm to a developing fetus are called teratogenic effects. Drugs and natural products that stimulate the growth of cancers are classified as carcinogens. Carcinogenic drugs interact with DNA and produce permanent genetic mutations. Patients taking controlled substances may develop dependence or tolerance to the drug's effects. Drugs are placed in controlled substance schedules according to their likelihood to produce physiologic or psychological dependence. Patients who have developed dependence to a drug must continue to take the drug to prevent the onset of withdrawal symptoms. Drug therapy is strongly influenced by whether the patient takes the medication as prescribed or whether medication is taken at all. Adherence to drug therapy is defined as taking the prescribed medication in the correct dose at the right time and without missed doses. Lack of adherence to drug therapy is associated with poor health outcomes. Adherence to the prescribed drug therapy is increased when patients believe therapy is beneficial. That is particularly important when the medication has substantial adverse effects. An ADR is an undesired side effect of a drug. An ADR may be mild, like sedation or nausea, or severe, like hepatotoxicity or seizures. ADRs are a principal cause of discontinuation of drug therapy. Even fear of potential adverse reactions is a sufficient disincentive for some patients to avoid taking their medications. Pharmacy technicians can assist pharmacists in reducing patients' anxiety about adverse reactions by alerting the pharmacist when patients have questions about their drug therapy and making certain patients receive pharmacist consultation for new medications. Adherence is approved when patients develop a regular routine for taking a medication. The pharmacist and pharmacy technician can work with patients to develop a routine for taking medications that fits the patient's lifestyle. Some pharmacies sell devices that prompt the patient to remember to take medications. Dosing schedules must be convenient and understandable if patients are to avoid missed doses or taking double doses. Adherence to drug therapy becomes more difficult as the number of medications prescribed increases. Some pharmacies even dispense medication in compliance blister packs. So that way the patients know if they miss doses, or it helps them stay on track easier. People with low socioeconomic status are at increased risk for low adherence. Poverty decreases the ability to afford medications and decreases access to healthcare when adverse events are experienced. When drug therapy is expensive, prescriptions may not be filled. When prescriptions are filled, patients may take less than the dose prescribed to make the prescription last longer. Pharmacy personnel can work with the prescribers to ensure that effective and affordable drugs like generics are prescribed and dispensed when appropriate. Pharmacy technicians can also contact insurance companies to obtain approval for non-formulary medications. And that's true, but only in some certain settings. So like when I worked at a specialty pharmacy, my job was to obtain approval for non-covered and non-formulary medications. But if you're working at your just standard retail pharmacy, that job is actually going to be more for the doctor's office. We would just forward them the information that they should change it because it's not covered, or possibly call them and tell them that it's too expensive. And then they can work with the insurance company to get it covered. That's usually how it works. ADRs are reported to the U.S. Food and Drug Administration by drug manufacturers, healthcare professionals, and consumers using the MedWatch FDA Voluntary Reporting Form 3500. The ADR reports are complied into a computerized information database called the Adverse Event Reporting System. Vaccine adverse events are reported to the Vaccine Event Reporting System. The reports are analyzed and mined for signals of safety issues.